Welcome, everyone. On behalf of Cambridge Health Tech Institute's Global Web Symposia series and our sponsor, Biomodels, LLC, I'd like to welcome you to Precision Medicine in Cancer Supportive Care. My name is Elizabeth Lamb, and I'll be the host and the moderator for today's event. I would like to introduce our presenter for today. He is Dr. Stephen T. Somas, founder, partner, and chief scientific partner for Biomodels, LLC. Welcome, Dr. Somas.
Thanks, Elizabeth, and welcome, everybody, and thank you for joining us. As you know, the topic for this morning's webinar is precision medicine and supportive cancer care. Before I start, I just wanted to tell you a little bit about us. Biomodels is a spin-out of Brigham and Women's Hospital in Boston. We were started in 1997. We're a preclinical CRO with an emphasis on translational models and outcomes around a broad range of disease categories. And really our total focus is the translation from preclinical concept to patients and really moving things into the clinic. I'm also this morning going to be sponsored by Primary Endpoint Solutions, which was spun out of Biomodels, really is in a response to requests for continuity in clinical trial, endpoint, biomarker, and genomic development. So much for the sponsorship. But let's get into the bulk of the presentation. As you know, probably 2 years ago, I think it was in 2015, President Obama talked about a precision medicine initiative in his State of the Union address. And that was largely driven by the fact that if you look at current response to sort of the standard forms of treatment, patient responses really are dismal. This slide just presents 6 very common diseases and gives you an idea of how patients respond to the standard of care for each of those. And as you can see, the current sort of one-size-fits-all approach really doesn't work. The reality is we've been doing patient-centric care for a long time. It's called individualized medicine and then personalized medicine and now precision medicine. But if you look at sort of the old rules, the historic rules of personalized care, really the first 2 are the basis for them. And they're really sort of a trial and error approach. And they're based on the clinician figuring if what he or she is doing works, you keep doing it. If what you're doing doesn't work, you stop doing it and switch to plan B. And we've all probably had prescriptions that were given to us. The doc says, try this for 7 days. If it works, great. If it doesn't work, we'll try something else. And that's been sort of the historic paradigm. There are 2 others that go along with that. One is number 3, if you don't know what to do, don't do anything, and that's sort of the no harm rule. And then, of course, item number 4, if you're an internist, don't refer your patient to a surgeon. But the reality is what really is new is the need to switch from what was reactive personalized care, in other words, based on observation and failure to respond, to a method that's prospective and predictive. And that's really what we want to talk about today with the goal of ending up with what's circled on the lower right of this slide. We know that patients represent a heterogeneous population in terms of how they respond to drugs and how drugs impact them. And what we want to end up with really is a combination where drugs are beneficial and not toxic. And in order for this to really have its maximum benefit both clinically and also on healthcare costs, it's really incumbent on us to try to understand this on the left side of this graph rather than waiting till we get too far to the right where really the horse is out of the barn. That's been taken in some areas almost to an extreme where there have been suggestions of genotyping newborns very early on to be able to understand over the long term what their risk of disease might be. And it's certainly not out of the question that once we know that and have additional information, we could also develop a personalized armamentarium for each individual based on the expected response to treatment and the likelihood of toxicities being associated with that. It's no secret that precision medicine is viewed as a growth business. This has been a huge incentive for pharma, clinicians, the government to drive the process forward. Price Waterhouse, in their report, pegged the current revenues per year as well over $250 billion, and that is likely to increase by at least 10% per year. Now, interestingly, in the field that we're interested in, and that we're speaking to today, and that's oncology, the NCI obviously has done a lot on focusing on precision care, but the focus for them has been, at least the stated focus, has been around the tumor, and not really the tumor and the patient. And certainly from the standpoint of supportive cancer care, it's incumbent on us to look at this really in a holistic way. Now, we know that regimen-related toxicities are not new. Since Madame Curie first started using radiation for the treatment of tumors, or Sidney Farber started using chemotherapeutic drugs for the treatment of leukemia, the numbers of and diversity of toxicities has been well established and documented. And this slide just is a summary slide of toxicities associated with chemotherapy. I would point out that as targeted therapies evolved, as pathway-directed therapies evolved, the diversity and numbers of toxicity continue to grow. And we know that toxicities are associated with poor clinical outcomes, not just around quality of life of patients while they're being treated, but it also attenuates patients' ability to tolerate their anti-cancer treatment. And so toxicities are limiting in terms of the effectiveness of patients' anti-cancer therapy. They reduce the functional status of patients. They have higher healthcare costs, and I'll give you some specifics about that in a second. And although I put unhappy patients here, I think we could really qualify that and say these patients are often miserable because of the toxicities which they undergo. Let me just give you some clinical examples. This is a patient with dermatitis induced by radiation. You can see the blistering, and you can imagine how uncomfortable this lesion is. The GI tract is almost ubiquitously involved with regimen-related toxicities. It starts in the mouth with these broad areas of mucositis and proceeds all the way down the GI tract to involve the oropharynx, the esophagus, and the intestine. And this is just an example of the diversity and severity of tissue-based toxicities. I also wanted to mention that while we are focused largely on tissue injury as a primary form of toxicity, systemic toxicities such as fatigue and cognitive dysfunction are extremely common. They're debilitating, and they're long-lasting. And by way of example, if you look at patients who are treated with psychochemotherapy for breast cancer, those patients will often have lingering fatigue lasting for 2 or 3 years after treatment. And what that does is although we feel like they're done with their cancer therapy, the impact of those toxicities ripples for years and prevents patients from going back to work full time or enjoying the things of daily living that we take for granted. And although we think of cancer therapy associated with supportive care and interventions for supportive care to focus largely on radiation and chemotherapy, I also wanted to point out that surgical therapy, although we think of it as being, very specific and very directed, also comes with a whole biological maelstrom of side effects that are biologically driven. So I don't think we can discard the potential of surgery as a driver of regimen-related toxicities. I mentioned earlier just that toxicities drive the cost of care. I just wanted to give you some examples of the incremental cost of care associated with some representative toxicities. Mucositis for patients getting chemoradiation for head and neck or non-small cell lung cancer is over $17,000 per treatment. neutropenia and thrombocytopenia, so consequences of myelosuppression in patients with ovarian cancer are significant. I point out these dollars are $2,001, so you can make the calculations and make them more current. Nausea and vomiting, significant, almost $1,500 per episode, and diarrhea, even moderate diarrhea, close to $3,000 per episode, and severe diarrhea where patients require hospitalization and fluid support over $6,000 per episode. So the toxicities from the standpoint of comprehensive cost of care really represent a significant driver of resource use. Fortunately, our thinking about cancer regimen-related toxicities has changed dramatically. The old thinking was that basically toxicities were the cost of doing business. They were inevitable, but they were worth the cost for extended survival. That paradigm has shifted dramatically in two ways. First, we know that toxicities may not be inevitable, or if they are inevitable, pharmacologically we can intervene and prevent them or mitigate them. And second, that patients are much more aware of quality of life than they have been in the past. And it wasn't survival no matter what. Right now, there's a balance between the quality of life associated with treatment and years of survival. And that kind of discussion happens more and more often now between oncologists and their patients as patients become much more involved in the treatment decision making and dialogue. And I just put a short list of examples of mechanistically based drugs or biologicals that are available to prevent toxicities and side effects. Some of these are approved, some of these are under development, but really what I wanted to leave you with is with the understanding that there's a lot on the table that undermines the assumption that there's nothing that we can do about preventing or treating regimen-related toxicities. Simultaneously with some old thinking that toxicities are not that common and or severe. And if you go back and look at the literature that evaluates new cancer regimens, often the toxicity reporting was dumbed down. And in fact, there was a recent paper in JCO where it was concluded that toxicities are at high risk of being underreported by physicians, and they're certainly underreported by patients because patients are afraid that if they bring up a toxicity, what that would result in is the oncologist dose de-escalating their treatment, and that would mean that they would get less than optimum cancer therapy. So at both ends of the spectrum, most of the levels, the incidence, the reported incidence of toxicities that's in the literature is really lower than if you query patients directly. And then finally, there was the old thinking, we'll talk about this in a second, the toxicities were solely the consequence of direct clonogenic cell death, so that there was no renewal of cells and there was consequent toxicity. And a classic example of this is myelosuppression, where the bone marrow tissue compartment was not specifically affected by chemotherapy, and as a result, patients became neutropenic. The reality is that toxicities are really the compilation of multiple biological events. And because of that, we know that not all patients are on an even playing field when it comes to toxicity risk. Certainly, clinically, we know that if you have 100 patients walk in the door with exactly the same tumor, exactly the same demographic, getting exactly the same treatment, some patients will sail through treatment and have no toxicities, and other patients will be miserable, some will get really, really sick, and some will die. And just as an example of that, if we look at epithelial-based toxicities, we know that for skin, the oral cavity, the esophagus, the rectal mucosa that's comprised of stratified squamous epithelium, The historic story has been if you gave radiation or chemotherapy, it non-specifically affected the basal stem cells of the epithelium. The tissue wasn't renewed, it became atrophic. It ultimately went on to ulcerate, and then if everything was okay, it went on to heal. And it was a very straightforward mechanistic concept. Unfortunately, it's not correct. So I think what we want to keep in mind is that things are not necessarily as they appear. And certainly with regimen-related toxicities, our ability to better understand the biological contributors to toxicity pathogenesis has been the key to development of both determinants of risk and also identifying opportunities for interventional targets. So, for example, if we look at patients or cells that are radiated, we know that there are a lot of biological signals that affect normal cells around the tumor, so-called bystander effects. And in fact, a lot of these mediators become systemic and can have distant or abscopal effects. And so if you look at a number of pathways associated with radiation therapy, you can see that aside from just direct DNA strand breaks and clonogenic cell death, there's a huge amount of biology going on, again, which offers opportunity for identification of risk and also for targeting of drugs. And likewise for chemotherapy, again, multiple pathways are initiated with drug therapy, and I'm talking about in normal tissue, not just tumor tissue, including oxidative stress, activation of the innate immune response and the inflammasome, activation of a series of transcription factors, including NF-kappa B, downstream activation of genes that affect cytokine production, and so on, and so on. And so there's a lot going on, and in fact, if you look at just a sample list of the canonical pathways associated with regimen-related tissue injury, you can see how robust this is and how diverse it is. And what's important to realize is that each of these represents a potential treatment target, and also realize that these don't happen in a segregated way. It's really a cascade and a grouping of biological activities that go on. I mentioned earlier about surgical complications, and I just wanted to throw up this slide to give you an idea of the diversity of biological events that are triggered following operations. So although we think, again, of surgery being very specific and limited, clearly any manipulation of tissue has the opportunity to produce a whole variety of biological signals. I also wanted to point out that all of these changes don't occur in a very compressed period of time. Some occur very early with treatment, some last for weeks and days, and some persist for years. So the ability to intervene with these and identify risk has huge opportunities in terms of affecting outcome. And most importantly, if we can reduce toxicity risk, that really gives the oncologist the opportunity to do and provide more aggressive cancer therapy. And that ultimately results in what we're all interested in, and that's better survival for our patients. Now, what are the key sources of toxicity risk? I sort of lumped them into three groups on this slide. Treatment-related sources of risk are ones that you're all familiar with. Some drugs are more toxic than others. The more you use, the more toxic they are. Same thing with radiation. But the fact is, we know that if we keep treatment constant, we still have differences in toxicity risk for different patients. And so there are factors that are associated with the tumor, and there are factors that are associated with the patient. Now, thinking of the tumor as being biologically active is actually a relatively new concept. Historically, tumors have been viewed as being sort of this growing but separated blob that had its own homogeneous cell composition, and the biology was really internal to the tumor, including cells that escaped and became metastatic. The reality is, as we know, tumors themselves and the surrounding tissue really represent a very complex tissue complex. And if you look at this biologically, and I know this slide is incredibly busy, so you'll be able to take a look at it more leisurely either by going to the journal or when the presentation is on the website. But what I wanted to get across in this slide was how robust biologically tumors are, not just internally, but also systemically. And I don't mean just metastases. I'm talking about mediators and molecules that are generated from the tumor that affect a broad range of different cellular targets. The other thing I wanted to mention and bring up is the role of the microbiome. It sort of falls, I guess, within the realm of the patient, but one of the things that we do know are that patients that get radiated or patients who get chemotherapy undergo some form of microbial dysbiosis. And that has effects not only on the tissue, it may have effects on patients' ability to metabolize drugs and on permeability of some epithelial tissues. This has been so far best well studied in the gut, but it's certainly not unreasonable to assume that we know that the microbiome of individual skins vary, their mouths vary, their other tissues vary, and that may be a contributor to risk. So it's something to keep in mind and something that we need to look at. So when we're looking at risk and responses to treatment, I think we need to keep a huge open mind and realize that we're not working with specific pathways or components that are firewalled or siloed. We have a lot of interaction with a lot of moving parts. So let's talk about approaches to applying precision medicine to supportive care. And there are really two major approaches to this. The first has been the approach, sort of the magic bullet approach, where the treatment would differentially target tumor tissue with drugs, but would avoid injuring normal tissue. And an example of this that we'll talk about in a second is some of the nanotechnology. The more common approaches are really listed in the last two bullets. And one is to be able to identify the best anti-tumor options for patients, largely based on characterization of the tumors as sort of the NCI initiative, and then on our side to determine the risk of toxicity for each option, and then put those two things together to select the most efficacious and least toxic option, recognizing that there are trade-offs and there may be choices. And then the second part of that is being able to predict the likelihood of patients' response to a specific toxicity mitigator, and then to design the treatment based on the probability of effective treatment and prevention. And for any of these things, it's really critical to realize that we're always walking a tightrope to be sure that any supportive care mitigator isn't protecting normal tissue at a cost of protecting the tumor or adversely affecting tumor behavior. And unfortunately, there have been some examples of sort of poor, that balance not being in a positive way in the past. So as I mentioned, one example of targeted approaches is what's been going on in the nanotechnology world. We know that nanoparticles, one of the things they do is increase endothelial permeability, and so in this model you can see a nanocarrier with an anti-cancer drug in the middle and then a specific ligand to identify the tumor on the outside, charging through capillaries. There's increased endothelial permeability. Ideally, the targeted ligand hooks onto the specific target on the cancer cell. There's endocytosis, and hocus pocus, the tumor cell is destroyed, specifically with no impact to normal tissue. An example of this, of a drug that's been around for a while, is Abraxane, which is a nanopreparation of paclitaxel, where albumin facilitates the transport and uptake to tumor cells. But what I wanted to point out from the supportive care standpoint is even this type of approach is not without toxicity cost. But the fact is that most of our patients get much less selective treatment with the goal of trying to destroy not only the primary tumor, but potentially distant and metastatic cells and locally advanced cancer, either with chemotherapy, with radiation, or with concomitant chemoradiation. So one of the questions that we've asked is, what can genomics as a tool bring to the table to satisfy two of our objectives? One is to determine the at-risk population, that is, prospectively, before patients ever get treatment, when they're treatment naive, try to identify who's at risk for toxicity and who isn't. And then second, to be able to ask the question, if we give a patient a specific agent to mitigate a toxicity, can we differentiate that population of patients that's likely to respond to that treatment from that group that doesn't respond? And I'd like to talk in the next few minutes with you about how this can happen. From a genomic standpoint, it's really important to point out, and I know I'm being redundant, that when we talk about cancer patients, we're talking about sort of two groups of mutations or genes, one associated with a tumor and the other associated with germline mutations. And the germline mutations are really the money mutations for us in terms of understanding toxicity risk and also understanding response to treatment. And the importance of this is not only with chemotherapy, but it also applies to radiation therapy, where a lot of standard regimens are driven by the most sensitive patients. And by having our ability to differentiate the spectrum of responsiveness to radiation, it may allow us to increase dose escalation for patients getting radiotherapy. So what's made this feasible? Sort of a number of things. One, even more than 15 years now, the Human Genome Project has been completed. So that was a huge advance. We have a much better understanding of the multifactorial basis for triggers of toxicity at the biological level, and the recognition that those biological drivers don't occur as independent variables. They occur in groups. The technology has advanced tremendously. I don't have to tell you that chip technology has moved at a huge rate. We all know Moore's law. And what's happened is, because of that, not only is the availability of chips and the complexity of chips, and by chips I mean microarrays, increased, but the costs have come down. Simultaneous with that, there's been greater computer power and data storage. We're all aware of the cloud, the ability to take huge amounts of data now and put those together in advanced computational methods. So put all of those together, and it's really been a great opportunity for us. Now, historically, genetic determinants of toxicity really have worked at been looked at three levels. One associated with drug metabolism, and others looking at the more biologically based signals. Drug metabolism and its impact on not just chemotherapy, but a variety of drugs has been established for a long time in the roles of genetics and genomics, and in terms of impacting that. An example has been DPD and its ability to catabolize 5-fluorouracil. It's a 5-FU, as you know, is a very common form of chemotherapy. It's used for a variety of cancers, breast cancer, colorectal cancer, a lot of the regimens have 5-FU as a significant component of that. It comes with a whole basket full of toxicities, and so if a patient is missing the gene to catabolize the drug, obviously the risk of toxicity goes way up. And as you can see, there are certainly portions of the population in which either complete or partial deficiencies of the DPD gene occur. But the other thing that we recognize is that the rates of toxicity far exceed the rates of gene deficiencies for metabolism. So there needs to be something else that's driving toxicity risk, and it turns out that factor is the association of toxicities with that broad pathobiology that we talked about. So then the question is, how do we look at that? And while there are lots of new ways to capture genomic data, and a lot of these, the iPhone, a lot of the stuff is in the headlines. You read about it. It's, the hardware is really, pretty sexy, but the real driver is the analytics, the computational part of this. That's what's really allowed us to move. And really there have been three sort of two classic approaches and one newer approach that I just want to talk about. One is candidate gene approach, then GWAS studies, and then sort of the newer machine learning and deep learning approaches that really seem to be paying off in spades. So the candidate gene approach basically would be, we'd get a group of us who are interested and expert in this area. We'd sit around and we'd say, okay, we're going to make a list of the genes that we think are the ones that are associated with risk. And then we'll take that list and we'll pare it down and we'll come up with the gene, the magic bullet that will really unlock the risk of the phenotype we're interested in. It's sort of like looking for a needle in a haystack. And in fact, that's really been the experience. The results of candidate gene studies looking at regimen-related toxicity risk have been consistently disappointing. This is a study by Barnett where they reported the results of over 1,600 patients with either breast or prostate cancer. Bottom line is there wasn't one gene that was identified, or SNP, that was predictive of risk and stood the test of validation. And one of the reasons for that is that we know that genes or SNPs function cooperatively. They're groups. Here's an example of just looking at different genes associated with radiation pneumonitis. That's a big problem in patients with non-small cell lung patients who are getting radiated. They develop pneumonitis. A significant percentage go on to fibrosis, which has a huge amount of mortality and morbidity. But the point of the slide that I wanted to make is it's not one SNP that's doing it or two SNPs that determine risk. The reality is it's groups. And so we have to be able to find groups of SNPs to do this. So sort of the flip side of the candidate gene, the single gene, approach, was the enablement of genome-wide association studies. And that largely occurred because of advances in technology that allowed us to look at huge numbers of genes, or really SNPs, at a single time. And SNP chip arrays now have up to 4 million probes. We know there are 25,000 genes. There are probably 10 million SNPs. They occur at about 1 every 300 base pairs. And that mutation, when it occurs in 1% or more of the population, is actually a mutation that we can link to complex diseases including regimen-related toxicities. So how does this work? So genome-wide association studies typically take a large patient population, separate them into a study group and a control group. They're almost all case control studies. You run the chips and collect all of the SNPs from the two. You basically throw it against the wall and see which SNPs are associated with a phenotype of interest. And, as I said, we're dealing with chip ranges of 1 million or 4 million. If you throw anything of that volume against a wall, something's going to stick. And so if you go and repeat the first experiment, again you get hits. The problem is they're not the same hits. And so what do? You do it a third time and say, okay, we're going to resolve this. You repeat the procedure again. This violates Murphy's first law of experimental studies, which says if an experiment works, you don't repeat it, but you do it anyway. And lo and behold, what happens? You get no matches. So GWAS studies are notorious for having a large number of false positives. And a large part of that is driven by the fact that given the number of potential signals, so 1 million or 4 million SNPs, the ratio of signal to subjects or samples is so unbalanced that the likelihood of getting misled is high. And in this slide, I just summarized the major differences between the candidate gene and GWAS studies. Primarily, the key thing is, around the number of variants, and also whether one is hypothesis-driven or the other is really hypothesis-generating. And so, as I mentioned, there are a number of problems associated with GWAS studies, trying to do too much in one experiment, small sample size, and random errors are those that are most frequently cited. So then the question comes, well, do we just throw up our hands and walk away, or do we come up with an alternative way to be able to identify these groups of cooperative genes or SNPs that can either predict risk or differentiate response from non-response without having to do experiments in which the sample sizes are ridiculously large? And one opportunity to do that is looking at machine learning and deep learning paradigms. And one is associated with the identification of probabilistic networks, and one can do that in a variety of ways. But for us, this network generation and generation of grouping of SNPs and genes has actually borne some significant fruit. So let me give you some specific examples. And what I'd like to do is I'll give you one about looking at toxicity risk around tissue, a second around toxicity risk associated with sort of more somatic toxicities, specifically fatigue, and then finally an example where we could differentiate responders and non-responders. So Bayesian networks have been around for a long time. Bayesian statistics, as you know, sort of counterbalances frequentist statistics. Is largely based on inference, which can be a good thing. You don't need to wake up every morning and look to see if the sun is coming up, probably for more than 5 days, to conclude that that's going to happen, hopefully for a long time thereafter. So the way that we've been able to leverage networks, and particularly Bayesian networks, is really to start with a three-phase, or use a three-phase process where we prepare the data by taking gene or SNP chip and using a coarse statistical filter that allows us to throw out in a fairly easy and quick way sort of genes and SNPs that we know that are totally extraneous. So if you think of a very broad bell-shaped curve, it's pretty easy to eliminate the extremes. And we can pare down, in the case of genes, we can go from 25,000 to 1,000 genes fairly easily. And then we put them through another process where we rank them based on significance. So we take those 1,000 genes, and then we probabilistically rank them, and then take the top 200, because we figure that that's a pretty reasonable number to know that that's going to contain the genes or the SNPs that are going to be able to answer the questions that we need. And then what we do is we, in an unsupervised way, look at how they interact with each other relative to the phenotype. So this is undirected. And at the end of the day, we end up with an optimal network that, in the case of mucositis in stem cell transplant patients, consisted of a SNP cluster of 87 SNPs that was able to predict with quite good accuracy, not only in the study population. So we do a lot of internal validation. So that would be like, if we said it worked well in the study population, it would be like testing it against ourselves, but also in an independent set of patients. And that's really a key with any of these tests, as you know, that they're validated using an independent set of patients. Another way to validate this, or a reality check, is to understand that regardless of the driver, what goes in the top of the funnel, there are only so many ways to get to a phenotype, and phenotypes share genes. So if we looked at diarrhea, or we looked at fatigue, or we look at cognitive dysfunction, it would not be unrealistic to think that the same genes that cause diarrhea in patients with Crohn's disease or IBD are very similar to the genes that cause diarrhea in patients getting chemotherapy, or patients who have Alzheimer's, and we identify those genes are similar to the genes that happen when patients get chemo brain or cognitive dysfunction, or fatigue that's induced by radiation, and genes that we see in chronic fatigue syndrome and narcolepsy. And in fact, when we did this, it's a good way to a good reality check of the genes and SNPs that we were able to isolate to predict risk. Now, in an alternative to Bayesian networks, we used another approach, again, machine learning approach with deep learning. This was a project that we did in collaboration with the NIH, in which we looked at the ability to predict fatigue in patients who were about to go or had undergone radiotherapy for prostate cancer. And again, this is a toxicity that not only is acute, but persists for a long period of time. So it's not related to anemia, or it's not related to sort of the acute drivers of fatigue, but rather the later ones. And what we were able to do using that methodology was, again, come up with a paradigm that allowed us to prospectively, so in treatment-naive patients, differentiate patients who would go on to be fatigued or non-fatigued following their radiation therapy. And then finally, we were able to use a combination of techniques to be able to differentiate patients who were responders or non-responders to a treatment to prevent oral mucositis induced by chemoradiation. So I'd like to just sum up now. I think we're really heading towards precision medicine in supportive care that defines really two major things. One, the population at risk of toxicities, and then two, identifies what works and what doesn't work in that at-risk population. Many of those factors are driven genetically, but to consider genetics only is naive. And to be truly effective and actionable, the analytics have to allow for concordant multifactorial drivers. So we have to be able to, and we can, with the machine learning tools that we're using now, be able to add information from the microbiome, information from demographic sources, information that is epigenetic, and be able to put all of those things together so that we can come up with something that really is precise in terms of its utility. Again, I know I've said this already, but just to emphasize it, personalized medicine, precision medicine is not a one-pony show. There are a lot of components to it. Often our work is compartmentalized. some of you work in a genomics lab, some of you work in a pharma lab, some of you may work in a microbiotics lab. It's really important that we talk to each other and that everything goes into a common pot if this is going to work. So if we put everything together, really, we want to have a preventive diagnostic risk assessment. We want to optimize the selection of treatment based on response probability. We want to avoid those interventions that are most likely to be associated with side effects. Once we put those three things together and create a hierarchy, then we can add pharmacoeconomics. We can add cost of care to get an equivalent outcome. And I think for us to ignore health economics in the current environment and context would be folly. I think it's part and parcel of what we do, and we have to be able to address that if we're going to have something that's clinically meaningful. So I just want you to keep this in mind. Think big and think broad. I think we are at a precipice of a lot of exciting new things happening, and we're certainly excited to move things forward. So again, I wanted to thank everybody for participating this morning. I know we don't have any more time. So my email address is on the bottom. Please don't be bashful about emailing me questions, or go to our website and you can email us that way. But I'll definitely respond to every note that I get. So thanks a lot, and have a good rest of the day.